Good morning, everyone. Welcome back to another CME session. I hope the new year is going well for all of you, and we are very, very excited to be back with a very interesting topic. And for the first time, we have a collaboration between Health Plus Fertility Center and Cleveland Clinic Abu Dhabi to bring this topic to you. So the topic today is fertility preservation in women with cancer. This is something that is extremely important, as we all know. And the interesting thing is that there's been just so much development in this field. And as a result of collaboration between oncologists, between oncosurgeons, between fertility specialists, we are now able to offer young women who unfortunately get diagnosed with cancer to then go on to have their own babies and preserve their fertility. So that is something that is very, very reassuring to women. And it's something that is a very, very good tool in our bucket to offer to our patients. So I'm very, very glad that we are going to be listening about this and learning more about what is really happening in the UAE and what is it that we can offer to our patients. So the speakers today, I'm very, very happy to have Dr. Stephanie Ricky, who's a gynecologic oncologist from Cleveland Clinic Abu Dhabi, and Dr. Nadia Najari, who is our very own consultant IVF specialist at Health Plus Fertility Center. So welcome to both of you, and thank you so much for taking out your time and sharing your expertise with all of us. We have participants here from all over the UAE, so we are going to be very, very happy and enlightened to learn about what's really going on. I would just request to go over the rules, the guidelines for the session. So it's going to be a 2-hour session, a very interesting one, and we're going to have a rich discussion at the end. So I do encourage all of you to stay till the end and also put down any questions that you have during the talks in the chat box so that I can address them to both our speakers at the end. Please keep yourself on mute during the talk so as to not disturb the speakers. As usual, there will be links posted in the chat box for pre-lecture assessment, later on for post-lecture assessment at the end, as well as an evaluation link for our CME. So I would advise all of you to please complete those 3 links while you're still in the session so that one, we get feedback from you, and secondly, it is also important for you to get your approval for TAM's DOH certificate on TAM. Please complete all of them before you end the session. If you have any questions, like I said, please post them in the chat box. And in the end, for your certificates, if you are working in Abu Dhabi under DOH, you will go to TAM and register for these sessions. They will be as 2 different sessions. So please register for both, and you will get 2 CME hours from DOH for this. For those who don't work under DOH, who are not licensed with DOH, you can send us an email to Academic Affairs. We will post that link in the chat box as well. So that's all about the session. Now we go back to our speaker. Our first speaker today is Dr. Stephanie Ricky. She's an assistant professor of OB-GYN at the Lerner College of Medicine of Cleveland Clinic and is a consultant gynecologic oncologist at the Oncology Institute at Cleveland Clinic Abu Dhabi. Prior to coming here, she was an assistant professor of OB-GYN in the Division of Gynecologic Oncology at the Cleveland Clinic main campus. She received her medical degree from the University of Connecticut School of Medicine in the USA, where she also went on to complete her residency and then did a fellowship in gynecologic oncology at Johns Hopkins Hospital, USA. Throughout her tenure, she has specialized in gynecologic oncology, completing over 3,000 operations, from minimally invasive surgery to cytoreductive surgeries and also heated intraperitoneal chemotherapy. Her research interests have focused mainly on clinical patient care, including rare uterine tumors, time to treatment, and survivorship in women with gynecological cancers. During her last 6 years at Cleveland Clinic in Ohio, she served as the gynae lead for the uterine transplant program, which is the largest disease donor program in the world. So we are very, very happy and honored to have Dr. Stephanie Ricky with us today to talk to us about fertility preservation in women with cancer. Over to you, Dr. Stephanie.
Share my screen. Okay, can you see my slides?
Yes.
Wonderful. Okay. Good morning, everyone. Thank you so much for inviting me to speak on this topic. It's something that, as you heard in my bio, has been sort of a passion project of mine. I was involved at main campus in the largest deceased donor uterine transplant, series in the world. And it was a lot of extra time and blood, sweat, and tears. But really it was for women who had no other option for fertility. And we were able to, in the program so far, deliver 4 healthy babies in that program. So we were really just excited about being able to do that. And this is fertility preservation, especially in the oncology patients, since GYN oncology is what I do every day, is something that I'm just very passionate about. So, it's not moving. My slides are not, there we go. Okay, so the outline for today's talk, I'm gonna talk about, obviously start with gynecologic oncology patients and just go over the 3 main cancers and what we can do for women with early stage disease, what fertility sparing surgical options that we have. And then I'm going to briefly talk about non-gynecologic female oncology patients. So go over like radiation and chemotherapy and what options we have there and how we can preserve fertility for these women. So the scope of our problem is basically that invasive cancer is diagnosed in 1 in 48 women before the age of 40. 1 second. Just minimize this. There are, of course, high survival rates, which is not a bad thing in women's cancer, but this is causing women to seek out pregnancy even with a cancer diagnosis, which is, I think, a hopeful thing, but we need to figure out how we can help these women achieve fertility and have a family, even with a history of cancer or a current cancer diagnosis. So for women with childhood cancers, there's a greater than 80% survival rate at 5 years. Breast cancer, patients with breast cancer now have a 90% survival at 5 years, which is phenomenal. And then early stage gynecologic cancers have greater than 90% survival at 5 years. So there are approximately 380,000 women of reproductive age who are cancer survivors and who are seeking fertility. So obviously cancer treatment can threaten reproductive health. And there are 3 predominant ways that cancer does this. One is direct damage to the uterus and or cervix and or ovaries. There's germ cell loss and destruction. And then of course there's damage to the hypothalamic pituitary adrenal axis. And I'm going to start really talking about direct damage to the uterus and cervix. And that's with gynecologic oncology patients. So my first topic will be cervical cancer. So for women with stage 1A1 cervical cancer and no what's called LVSI or lymphovascular space invasion, a cervical conization with negative margins is actually adequate treatment. Preferably, it's a non-fragmented specimen with 3 millimeters of negative margin. And if the margins are positive, then the options include repeat cone biopsies, simple trachelectomy, or radical trachelectomy. Now, for women with stage 1A2 cervical cancer or stage 1A1 with LVSI, fertility sparing treatment can be either a conization or a radical trachelectomy. And for those who aren't aware, radical trachelectomy is basically where we remove the entire cervix, but also the parametria, which is the tissue next to the cervix. And this is a very I would say it's not a difficult procedure, but it's not a commonly performed procedure. And so not many surgeons have the training and or capability to do it. So as we know, trachelectomy can be performed vaginally or abdominally. And if it's performed abdominally, it's done via XLAP. We used to do these through using minimally invasive techniques. However, with the recent LAC trial that came out showing that minimally invasive surgery is not an adequate surgical option for women with cervical cancer, now all of these approaches are either vaginal or abdominal. Of note, the comprehensive pelvic lymphadenectomy can be replaced with a sentinel lymph node assessment instead of doing, instead of the morbidity of a full pelvic lymph node dissection. For stage 1B1 cervical cancer, the majority of data is for tumors less than or equal to 2 centimeters in size. There's some data for tumors up to 4 centimeters in size for radical trachelectomy and pelvic lymphadenectomy. And just of note, fertility sparing is not recommended for neuroendocrine tumors or adenoma malignum. So given the goal of fertility sparing surgery in pregnancy and childbearing, how feasible is it that after fertility sparing surgery for cervical cancer that a woman can actually get pregnant? So after a radical trachelectomy, approximately 50% of women are able to successfully conceive. There is about a 20% miscarriage rate in the first trimester. Second trimester loss is actually rare. However, of those patients who get to the third trimester, the risk of preterm delivery is approximately 25%. And most of that is obviously insufficiency of the cervix after it has been operated on. So as is a general theme with fertility preservation, the key is to think ahead, discuss all options, and ensure women are being seen by the appropriate specialists, which often requires a multidisciplinary approach. So women should be seen by a gynecologic oncologist for counseling regarding treatment options and surgery. Once patients are thinking of conceiving, they should be seen by MFM or maternal fetal medicine for preconception counseling and intrapartum follow-up, including things like cervical length with appropriate interventions based on the findings. So things like cerclage and vaginal progesterone. And if women are not able to conceive spontaneously, obviously referral to reproductive endocrinology to discuss assisted reproductive technology is appropriate. So shifting gears a little bit, let's talk about endometrial cancer. So endometrial cancer is actually the most common gynecologic malignancy in the developed world. So the incidence in the United States in 2016 was actually over 60,000 cases, and it actually just has steadily increased over time. So it's one of the few cancers that if you look at the WHO information, that actually is increasing in incidence and not decreasing in incidence. And so in general, the peak incidence is 60 years of age, but actually 25% of women are premenopausal and up to 10% are less than 40. So for type 1 endometrial cancer, which I'll be focusing on today and accounts for about 90% of the cases, it's typically hormonally driven. So the histology is most commonly low grade, and there are well-established clinical risk factors, including endogenous or exogenous estrogen excess, obesity, nulliparity, diabetes, hypertension, all of the metabolic syndrome. In premenopausal women, the data actually suggests that type 1 endometrial cancer is less associated with excess estrogens and more highly associated with excess androgens in combination with progesterone deficiency. So these patients are very often chronically anovulatory with an increased period of proliferation. Excuse me. So in this traditional schematic of the menstrual cycle, you can see that low progesterone is essential for proliferation of the endometrial lining. In these women that have has often become a persistent state, and thus progesterone deficiency in premenopausal women can actually lead to increased endometrial proliferation. So when approaching conservative management of a woman with endometrial cancer, the first thing is to consider an MRI to rule out myometrial invasion. Given that of the available radiographic modalities, MRI is the most accurate. So remembering that if negative, you can be very confident of a low risk of invasion. But if the MRI is positive for invasion, only about 50% of them actually have, of those women actually have deep invasion. So it's a pretty good tool. And then the second thing to consider is to do either a DNC in the operating room or a hysteroscopy prior to initiation of treatment. I personally do a DNC in all of these women. And this, I think, improves diagnosis and the success of treatment because you're able to get a much more aggressive sample. Patients should be followed with repeated endometrial sampling every 3 to 6 months until resolution or they undergo a hysterectomy. The experts differ regarding whether 1 or 2 negative biopsies should be obtained prior to sending the patient to an infertility specialist. I like 2 negative biopsies prior to allowing the patient to go ahead and get pregnant. And then because once the disease has resolved, the patient, the recommendation is the patient pursue fertility immediately. And this often requires the help of REI. And if the woman is not planning to pursue fertility immediately, then maintenance with whatever form of whatever form the patient prefers, either an oral contraceptive or a levonorgestrel IUD, is recommended. But I think we can do more for these women. So things like sending them to a nutritionist or having them at least consult with a bariatric surgeon if they're morbidly obese. These are things that are going to help them in the long run, treat the underlying problem. And then basically once childbearing is completed, then women should consider definitive treatment. And I recommend this for all of my patients, so that they undergo hysterectomy once once their family is completed, because the recurrence rates are up to 20% or more. And then I think it's also interesting that when you are performing preoperative or pre-treatment evaluation, if they do have an adnexal mass, then this adnexal mass should be removed prior to initiating treatment, because there's about a 10 to 30% chance of a synchronous primary with some of these cases. So in terms of forms of progestin, there are multiple different forms that have been used. Oral forms are megestrol, medroxyprogesterone, progesterone, norethindrone acetate, or whatever we have available here in the UAE, because it's very difficult somehow to get things like progesterone and estrogen here. And then megestrol is the most commonly used oral medication in the United States. And typically the starting dose is 80 milligrams twice a day. So the best studied form is actually the levonorgestrel IUD, the Mirena, which I love and I use a lot. And this releases 20 micrograms of levonorgestrel per day. I think it's important to, when you're following these women, to rediscuss the plan after each biopsy, just to keep them motivated, and know that if there's no response at 3 months, that at that time a second modality should be added. So if they have something like a levonorgestrel IUD, then usually at 3 months, if there's no evidence of stromal decidualization or progestin effect, that I add an oral progesterone to for those women. And also, things like, addressing compliance issues. If they're taking oral medication, obviously with an IUD, compliance is not an issue. And also consider dosing with regard to the patient's weight. So if they're a higher weight, and there's no response at 3 months, then maybe the dose has to be increased. And I think it's also important to know that if there is stromal decidualization and no response to progesterone treatment, then it's less likely that they will actually, that their lesion will resolve. And this is something that's, it's a difficult conversation to have with the patient, but I think it's important to keep the patient aware of what's going on. So there was a meta-analysis of studies looking at medical management endometrial cancer in premenopausal women. And this was done looking at 30 studies between 1985 and 2015 for 400 patients. And actually there was an astounding 70% resolution of endometrial cancer in these women. So the median age in the study was 32. The median duration of treatment was 7 months, and the median time to resolution was 6 months. So that kind of gives you an idea that if a patient is not, they're not seeing any stromal decidualization or progestin effect by by 6 months, that this is probably not working, because most of the time women do resolve, their lesions do resolve in the first 6 to 9 months. And the median follow-up for these women was 41%. 30 to 40% were able to get pregnant, and the recurrence risk was 34% in these women. So like I said, I think it's really important that once their family is completed, that they undergo completion hysterectomy. That's my bias as a GYN oncologist, since I see cancer every day, but they do have a high recurrence risk. So again, just to review, the patient should be sampled every 3 months. And there's no cut and dry answer as far as how long you wait for a response. In the literature, you can find most commonly that you can wait up to a year for response. I tell my patients at the outset that if they have not cleared their cancer by a year, that I recommend hysterectomy at that point. And I think repeatedly it has been seen that the majority of patients who are going to respond will have significant evidence of improvement by 6 to 9 months. So again, that 6 to 9 months is really the sort of magic time. There are responses times for over a year and even up to 3 years that have been documented in the literature in women who refused hysterectomy. The data is still poor, but as best we can tell, persistence may be more likely in women with a higher BMI, as well as those with minimal response at the first biopsy, especially if there's no evidence of progestin effect on the tissue. And again, the progestin effect is usually seen in the form of stromal deciddualization. So once the disease is resolved, ideally patients should pursue fertility immediately. And again, usually this is with the help of a reproductive endocrinologist. And if they're not planning to pursue fertility, then they should be maintained either on an OCP or continue with their IUD. So once childbearing is completed, women should consider, and I highly recommend this, definitive treatment with hysterectomy. And the recurrence, because again, the recurrence rate is, they say 20%, but there are many studies that show that it's much higher than that, up to 35%. If medical management fails, it's important to continue to discuss fertility sparing options. So things like hysterectomy and salpingectomy with the retention of the ovaries. So the risk of ovarian involvement in early stage and no gross adnexal involvement is less than 1%. So oocyte harvesting and cryopreservation prior to surgery are options for these women. So thinking ahead for these patients. So young women with endometrial cancer or even complex atypical endometrial hyperplasia should be seen by gynecologic oncology in order to discuss medical management as a fertility sparing option. So if the treatment is successful, giving their underlying hormonal milieu, if you will, these patients are unlikely to be able to conceive spontaneously. So sometimes they just need something as simple as Clomid, but they should be seen by reproductive endocrinology for endocrine and infertility management. If the treatment is not successful, then they should also be seen by REI if they're interested in pursuing like pre-surgery oocyte harvesting. So, and I think it's important to know that other disciplines can be helpful in managing these young women. And for those who are obese, endometrial cancer and ovulation is sometimes their first presentation of the metabolic syndrome and a lifetime of resultant medical problems. Helping these women lose weight through referral to a nutritionist, exercise program, bariatric surgeon, things like that can impact on only the likelihood of success of resolution of disease, but also reduce the risk of other comorbidities. So switching gears to ovarian cancer, the NCCN guidelines say that unilateral salpingo-oophorectomy and preservation of the uterus and contralateral ovary can be considered for women with apparent early stage disease and or what they call good risk tumors who wish to preserve fertility. So what are good risk tumors? I mean, it's kind of like a misnomer, but basically things that are early stage, low malignant potential lesions, malignant germ cell tumors, malignant sex cord stromal tumors. But they do say that comprehensive surgical staging, and then they're talking about, lymph node dissection and, peritoneal and omental biopsies, things like that, should still be performed to rule out a cold higher stage disease, but may be omitted in the pediatric and adolescent population for kids and teenagers who present with malignant germ cell tumors. So looking at borderline ovarian tumors, the incidence is between the ages of 40 and 50, but about 10 to 15 years earlier, which is about 10 to 15 years earlier than invasive ovarian cancers. So the frequency of borderline tumors is actually highest relative to invasive ovarian cancer in young women, 15 to 29 years old. So you will see this in this patient population. Interestingly, white women have about twice the risk of developing this than compared to to Black women. And to answer the question regarding the safety of fertility-sparing surgery in these borderline tumors, Poncelet, who in France performed a retrospective multicenter cohort study of about 300 women. They were all stage 1 borderline ovarian tumors, and they either went a cystectomy, a unilateral salpingo-oophorectomy, or a BSO. And while some patients had long follow-up, about the median follow-up for the study was only just over 1.5 years. So based on these women in that time frame, they found that the risk of recurrence after cystectomy was 30%. After USO, it was 11%, and after BSO was only 1.7%. And this was statistically significant. So the literature has been fairly consistent in reporting that the risk is higher the more conservative the surgery is. So meaning that the risk is highest with cystectomy, then unilateral salpingo-oophorectomy, then BSO. Multiple retrospective studies have shown that fertility-sparing surgery for borderline tumors will not compromise survival, and women should be made aware of that. Recurrence rates are about 10 to 50%, so high, but recurrences are mostly borderline in nature and rarely ever invasive in this young group of patients. And management is surgical and in most cases curative for these women. There's no strong evidence that reproductive function is compromised by the fertility-sparing surgery. There's also no evidence that women who undergo fertility-sparing surgery and become pregnant are at any increased risk of disease progression or death. But recurrences years after the primary surgery are not uncommon. And that's why some people advocate for completion surgery after childbearing is completed. And I think this is a discussion that needs to be had between the doctor and the patient. But this is, like I said, this recommendation is controversial and is probably most reasonable for a subset of women who have high-risk histologies based on their pathology. So what about women with invasive epithelial ovarian cancer? So not just borderline tumors. So women who desire fertility preservation should clearly understand that data regarding outcomes are limited. In particular, there's little information on the frequency and outcome of recurrent disease or the safety of ovulation induction or hormonal contraception. So young women with a well-differentiated lesion of one ovary who have had a full staging operation but limited organ extirpation to preserve childbearing are advised to undergo hysterectomy and removal of the remaining ovary upon completion of their families or by the age of 35. All of these women should be tested for BRCA and counseled accordingly. So let's look at germ cell tumors. So primarily in women 10 to 30 years old is when these tumors occur. So fertility-sparing surgery in the form of USO has been repeatedly shown not adversely impact outcomes. So specifically looking at USO versus BSO with or without hysterectomy and additional staging, the vast majority of women actually regain their menses if obviously they've retained their uterus. And there are old studies that have shown that at least 30% have had successful pregnancies. But again, follow-up time is always limited in these studies. Now, looking at cystectomy versus unilateral salpingo-oophorectomy for germ cell tumors, generally cystectomy is not recommended for these cancers. There's extremely limited retrospective data where the diagnosis was made postoperatively and showed that women with dysgerminoma and immature teratoma who had a unilateral salpingo-oophorectomy and chemotherapy had similar outcomes to those with USO, but again, data is very limited. Looking at sex cord stromal tumors, 12% are under the age of 30. Fertility-sparing surgery with USO is included in the NCCN guidelines and recommended for stage 1 disease. Thankfully, 95% of sex cord stromal tumors are unilateral. Cystectomy is not recommended. Thus, at minimum, they recommend unilateral salpingo-oophorectomy, washings, resection of the suspicious areas, and biopsies. So the contralateral ovary need only be removed if it is grossly abnormal, and the uterus may be left in situ even if both ovaries are removed. So for women who present with incomplete staging, basically as a G1 oncologist, I would consider reoperation only if there's residual disease on imaging, and if clinical assessment, like tumor markers, that kind of thing, show no residual disease, then observation is a viable option. In order to think ahead for these women for fertility sparing treatment, the key, I think, is clear conversations with the patient to understand her desires, like for what she would want in each different scenario, and she has to have a clear understanding of the risk she's assuming, but also the benefits of the different viable options. So now just looking in general at the female oncology patient, not necessarily GYN, I think there's a few factors to consider, things like rationale for and factors impacting fertility preservation options. And I think Dr. Nadia is going to go over a lot of this information. And so I'm not going to go too in depth into it. But basically, if you are a normal woman, your window of fertility is from approximately 10 to 40-ish. So with highly toxic chemo, that window can close precipitously with initiation of treatment, or that window may continue through chemo with a steady decline. So how do we know, what do we do to help these women? So there are 4 major studies that address fertility after cancer treatment. There was the Childhood Cancer Survivor Study with over 3,000 patients from the US and Canada. There was the Norway Radium Hospital Study with 3,500 patients. And then there was the 575 Hodgkin's lymphoma patients who participated in a clinical trial, and California Cancer Registry data with about 1,100 patients. And what we take away from these trials is basically that pregnancy rates appear to be 50% of controls. Infertility rates appear to be 50% higher than controls. There's scant mixed data on the use of assisted reproduction in survivors, and we need more contemporary cohorts and better estimates for the residual window of ovarian function. I think it's really important to note that there is, in general, a feeling that women have in this space that they have no choice or control over their fertility. And I think after the studies that have been done and published, that ASCO, which is the American Society of Clinical Oncology, actually came out with a clinical practice guideline based on this data, because basically young women their fertility was being completely ignored. So the guidelines state that before cancer therapy, a medical oncologist should address the possibility of infertility with patients treated during their reproductive years. They should be prepared to discuss fertility preservation options and/or to refer all potential patients to appropriate reproductive specialists. And they should advise patients regarding potential threats to fertility as early as possible in the treatment process, so as to allow for the widest array of options for fertility preservation. And I can say, as an oncologist, this is sometimes not an easy thing to do, because when you're trying to save someone's life, you're trying to address that first. But it's really important to have this discussion very early, and I often have it with the patients, at least mention it and talk about it and have them think about it at the very first visit of their diagnosis. So obviously in these women, the multidisciplinary approach is essential, and probably even more so with non-gynecologic oncology patients, because a gynecologic oncologist, I think, is a little more attuned to a woman's reproductive health than a medical oncologist who is seeing men and women of all ages. And so ideally you would have an oncologist, a gynecologist on this team, or in the case of men, for a urologist, a reproductive endocrinologist, a fertility navigator, and then obviously research personnel, because there's not a lot of data in this space. And again, the multidisciplinary team will be in communication to discuss the treatment plan. So does it involve surgery? Does it involve chemotherapy, radiation therapy? And if it's chemotherapy or radiation, what agents are going to be used and what will be the cumulative dose? Because that will be the crux of whether or not a woman's fertility will be impacted. There are several resources and mechanisms for calculating fertility risk, including different online portals and specific calculations using the different alkylating agents like cyclophosphamide as the point of reference. And using those calculators, then a team can place the patients into low, intermediate, or high risk groups. And with the high risk group has over an 80% chance of developing infertility, that undergoing this regimen will compromise that woman's fertility. So let's talk a little bit about the different modalities. So radiation and gonadotoxicity, the dose of the ovaries and the uterus matters. That's the kind of the crux of the situation. So the younger the woman, the more resilient her ovaries, and obviously the older, the less radiation is required to induce ovarian failure. So to give the extremes, at birth, like 20 gray is likely to induce ovarian failure. By age 40, a dose of only 6 gray can induce ovarian failure. And just so you're aware, something like pelvic radiation for endometrial cancer, that's 5,000 gray is delivered to the pelvis. So that kind of gives you an idea of how little radiation that actually is. In terms of the uterus, pelvic radiation can lead to abnormalities of the pelvic vasculature, which can decrease uteroplacental perfusion, as well as cause myometrial fibrosis, which can decrease uterine elasticity, desensibility, and volume. And there can also be injury to the endometrium, which may prevent normal deciddualization. So the uterus is actually more vulnerable to radiation before puberty than after puberty. And obviously things like, sex steroid replacement in these patients after treatment can significantly increase the uterine volume, endometrial thickness, and the uterine blood flow. Two of the standard care methods for fertility preservation with radiation are gonadal shielding and ovarian transposition. And ovarian transposition of the ovaries is basically where someone like myself, a surgeon, moves the ovaries away from the pelvis into the upper abdomen and out of the radiation field. So basically, while this has a success rate of about 80%, the flip side of the coin is that it's actually very difficult to retrieve oocytes for transposed ovaries. So I think if the patient desires oocyte retrieval, this should ideally be done before ovarian transposition and of course before radiation. So usually I try and have these, because this happens often for my cervical cancer patients. And so I will have them see REI prior to initiating any treatment or surgery. So if we look at chemotherapy, cyclophosphamide is an alkylating drug, which is one of the best documented and most potent chemotherapy drugs in inducing ovarian failure. So it's commonly used for things like lymphoma and breast cancer. We don't use it for GYN cancer. But basically the effects of cyclophosphamide are age and dose related. So as with the radiation impact on the ovaries, because they have more remaining oocytes, younger women are affected less often than older women. So studies have shown that the cumulative dose of about 5.2 grams induced amenorrhea in all women over the age of 40, whereas almost double the dose, like almost 10 grams, was required to cause amenorrhea in younger women. So there are very specific calculations for different drugs using cyclophosphamide as the reference point. And in order to ascertain what cumulative dose is likely to significantly impact fertility, known as something called the cyclophosphamide equivalent dose. And this is basically just a list of examples of how the cyclophosphamide equivalent dose is calculated. So when you're looking at female fertility preservation methods, there you have sort of the standard care and you have the experimental options. So we kind of talked about the surgical options, gonadal shielding, about ovarian transposition. The other options are going to be talked about by my colleague, Dr. Nadia. I'm sure she's going to go over this in detail. But I think that for me, and I probably hammered this home, pretty readily, but the key for fertility preservation is that it generally has to be addressed before any treatment. So in the, flurry of a cancer diagnosis, it can often feel like a low priority for the physician and the patient. But unfortunately, if that conversation is held too late, it will no longer be an option. So before initiating treatment, options for fertility preservation, as discussed, embryo oocyte banking, GnRH agonists, as well as surgical options that are fertility sparing, have to be addressed. The patient has to see a reproductive endocrinologist prior to starting treatment. After treatment, there's a lifetime of survivorship issues, and that is when the actual pregnancy attempts kind of come into play, and a woman's ability to become pregnant and possible need for assisted reproductive technology is going to be, there again. And also this is, things like sexual dysfunction, estrogen deprivation symptoms also are an issue, but that's an entire other talk. So there are many oncofertility resources that are available for women and for physicians. These are from the United States, so they are in English. I apologize, I don't know if there are any local ones that are in Arabic as well, but these are free and available to any patients who wish, or physicians who wish to use them. Thank you so much for giving me your time, and I'll hand it over back to Dr. Neha.
Thank you so much, Dr. Stephanie. That was really very interesting and very comprehensive. I think you've covered obviously you covered all the gynecological cancers and a little bit of insight into other cancers as well. And I really like the thought that you've left us with, that, this conversation and this discussion has to be done early on. Sorry, can you hear me now?
Yeah.
So just to have that conversation early on, and that's very important for me as a gynecologist sitting in my clinic, because sometimes we are the first ones to sort of suspect or diagnose it before we send them to you. And, to start that conversation even here while they're still not yet confirmed, or even once they're confirmed with the diagnosis, so that they can start thinking and planning accordingly. And I'm, very happy to say that, even in the UAE now, we have a lot of women. I have had patients who've had breast cancer and have gone on to have their babies delivered through, conceived through IVF and then delivered here in the UAE. So it's looking very, very positive for them. And it's so, it's so rewarding. I mean, even for me, just when they deliver their baby. So I can only imagine how rewarding it must be for you to treat them and go on to see them come back with their babies. So thank you so much for that. And we don't really have any questions in the chat box yet. So we let people think over what you've discussed and maybe take all the questions in the end. Meanwhile, I'd like to then go on to the next part of our session, which is by Dr. Nadia Najari. She is a consultant reproductive endocrinologist and IVF specialist with more than 21 years of experience. She has worked as a physician in leading healthcare organizations in not just in UAE, but in Germany as well. She's an expert in IVF segmentation, which improves implantation success, with a special focus on recurrent implantation failure, recurrent miscarriages, fertility preservation before cytotoxic therapy, endometriosis, hormonal imbalances, and genetic disorders. Her experience in this subspecialty is more than 16 years as a board-certified gynecologist and a subspecialist in gynecological endocrinology, reproductive medicine, and many years of work at University of Bonn as deputy director in Germany and in the UAE as in multiple organizations, as consultant, as even as head of department. So she also has a PhD with excellence from RWTH Aachen University, Germany, and has participated as a speaker, as an expert in multiple conferences, and we're just very, very happy to have her as a consultant at Health Plus Fertility Center, because it's a pleasure to work with her, and she is so lovely with her patients. So I will just now hand over to Dr. Nadia, who will then take us through the other aspect of fertility preservation in women with cancer.
Very much for this kind introduction. I will share my screen. don't know where to find it.
Just at the center lower end of yours, there's a green thing saying share screen.
My screen well, so I don't see my presentation.
Ah, okay. So if you go to share screen, you can take the first option on the left top. That will share your entire screen. Yes, perfect. We can see it now. But we cannot hear you, Dr. Nadia, for some reason.
Can you hear
Yes,
me?
now it's better. Yes, yes.
Okay, good. So thank you so much, Dr. Niha, for the kind introduction and invitation, and great presentation from Dr. Stephanie. So I think that I have to remove some slides because she explained everything perfect in order.
I think you need to be a little bit closer to your computer because your voice disappears when you're a bit far.
Okay. How can I go to the next slide?
You can either use the mouse or you can use the next or the downward arrow key on your keyboard.
Okay, thank you. So I don't have anything to disclose. Most information sources come from Fertility Protect network, from ESRM, from Israel. So by the end of the presentation, participants will be able to describe the importance of fertility preservation as part of comprehensive cancer care for reproductive age women, understand the cancer treatment and their impact on fertility, discuss what current fertility management option exists and understand it. They may be able to describe fertility preservation options that are available and have awareness, and they will know about the availability of fertility preservation techniques. What do we know is that the cancer in females of reproductive age account for nearly 10% of new cancer diagnoses, impacting 87 women per 100 women annually. The most common cancer presenting in this cohort include breast cancer, thyroid, cervical, uterine cancer, melanoma, lymphoma, and colon carcinoma. Women diagnosed with cancer, which is life-threatening, and facing cancer treatment, which is itself threatening for their fertility, may have to make decisions very quickly regarding fertility preservation with specialist fertility services, whilst planning care for their treatment of cancer, which with oncology services. These decisions are extremely stressful and complex, and those consequences will impact one woman's quality of life for the rest of their lifetime. Therefore, it is vital they feel supported in making the right decision for them, whilst also having to deal with the cancer diagnosis and its treatment. However, the existing evidence suggests that women do not feel well supported in their choices, with many patients finding the process challenging and missing out on fertility care at this crucial time. Unfortunately, cancer treatment often results in loss of fertility. The risk of premature menopause or premature ovarian insufficiency is related to the patient age, the ovarian reserve, chemotherapeutic agents, and the total dose received. The decision for or against fertility preservation depends on the prognosis, the risk of fertility, and also an individual factors as prospective family planning. We know also that the eggs peak in number during fertile life undergo degeneration, so atresia, and do not regenerate. Remarkably, the most eggs women will have are when she is a 20-week-old fetus with approximately 6 to 7 million eggs. At the birth, the number of eggs falls to 1 to 2 million. And at puberty, she has only 300 to 500,000 remaining eggs. From puberty through menopause, it is estimated women will ovulate about 400 to 500 total eggs. Although female fertility declines with advancing age, it is difficult to predict the overall rate of reproductive decline. The quality of women's eggs is highest in her mid-20s to her early 30s, representing the most fertility period in her life. After the early 30s, both the quality and quantity of eggs begin to decline, resulting in a decline of fertility potential, with the most significant declines occurring in the mid-30s and early 40s. The decline in both egg quantity and quantity might manifest in a longer time to conception. As a result, fecundability, that means the probability of achieving a pregnancy in one menstrual cycle begins to decline significantly in the early 30s, with a more rapid decline after the age of 35. And in this diagram, we can see the age in the x-axis and the number of the follicle in the y-axis. And we can see the optimal fertility period and the decline of the egg numbers and also the quality. Cancer treatments such as chemotherapy, radiation, and surgery may destroy a person's ability to have children later in life. The risk of premature menopause is related to the patient age, as I told, chemotherapeutic agents, and total dose received. Here we can see almost the same diagram. Then we see here the age of the patient, the x-axis, and the primordial follicle population and concentration. And we see that it's declining with the age. But here, if we give radiation chemotherapy, the loss of follicle is very, very quick and very strong. Here, when the patients have the diagnosis of cancer, the oncologist, they will send them to us. We will do the first consultation and we'll discuss with them. We assess the patient, we do ultrasound, we discuss about the general health, the risk of, we discuss about the ovarian reserve, we do blood tests to check the ovarian reserve, like AMH. We do the ultrasound to check the antral follicle count. We explain the fertility preservations treatment and the options. We explain everything, and then the patient they will also know the risk of fertility preservation, the chances of fertility preservation, and we send the patient to sometimes to a mental health counselor, to genetic counselor. So it's multidisciplinary team. We are working together to help the patient in this situation. Fertility preservation is a type of procedure used to help keep a person's ability to have children. A fertility preservation procedure is done before a medical treatment that may cause infertility, such as toward radiation therapy or chemotherapy. With 10% of cancer patients being younger than age of 40, so the cancer survivor increase we have a great therapy for cancer, and people and patients that will survive this cancer. The preservation of fertility in women becomes a critically important topic to the patient and their families. The ability to easily preserve the fertility prior to cancer treatments can provide hope at the time of diagnosis for families later in life, and also this hope that given to the patient that after the cancer treatment, we will kill the cancer and the patient can have a beautiful life and she can have family. This is helping her psychologically too. Which option do we have? Women should be counseled and on established options such embryo banking, egg banking, ovarian tissue banking, and ovarian transposition. And it depends if the patient is taking radiotherapy or not, because the effect of radiotherapy on ovarian function are very considerable. A dose of 2 gray to the ovaries reduces the follicle density by half. The dose for induction of a premature ovarian insufficiency or premature menopause in 30 years old woman is specified as 16 gray. So the ovarian transposition should be considered when targeted radiotherapy is performed in the pelvic area. In addition to the benefit and the risk, alternatives such cryopreservation should be discussed. A combination of different fertility preservation techniques is also possible and has to be addressed and explained. Ovarian transposition is not appropriate in patients who undergo total body radiation. It's clear pelvic radiation is often performed in cancer like Hodgkin's and non-Hodgkin's lymphoma, rectal cancer, Ewing sarcoma, pelvic of the pelvis, and cervical cancer. For a unilateral transposition, plays a role to allow spontaneous conception via the remaining ovary. After radiotherapy, the ovaries are placed back in their normal position. And we have, again, another experimental treatment or procedure is IVM, where the oocytes can be collected from the ovaries with a very, very mild stimulation or without ovarian stimulation, and then matured in the laboratories. Depending on the cycle phase which the patient is coming to us and she wants to have a stimulation, the stimulation can be done in early and mid follicle phase and late follicle phase and luteal phase. When we stimulate the patient in the early to mid follicle phase, the conventional antagonist protocol with follicle stimulation hormone or HMG, so human menopausal gonadotropin, addition of the antagonists, we give antagonists when the follicles are 13 or bigger than 14 millimeter, and we trigger the ovulation with gene H agonists with triptorelin. Stimulation start as a third in the can start in the late follicle phase 2, and you can stimulate in the luteal phase 2. And sometimes we do double stimulation. We stimulate stimulation with the classical agonist protocol as well as ovulation induction with gene H agonist is initially performed, and it can be assumed that the first stimulation can also be started in each cycle phase. So random stimulation could be stimulated, can stimulate in the early, mid follicle phase, late follicle phase, luteal phase. The time required for double stimulation is long, is circa 30 days. Normally we stimulate for 10 to 2 weeks, but if we do double stimulation, it may take 30 days. With IVM, as I discussed, we can collect the the follicle from the ovaries without ovarian stimulation or with mild stimulation and matured in the laboratory. Women undergo ovarian stimulation with gonadotropin cause the production of multiple eggs, which are removed and frozen for storage and future use. Here in the left side, we can see the follicle, one follicle, it's normal natural cycle without stimulation. And if we stimulate, we see multiple follicles maturing. And after the follicle mature, we go and we do office or oocyte retrieval by a needle and aspiration under ultrasound guidance. Here we see, this is the vagina, this is here the probe, and we aspirate the follicles under general anesthesia. The egg are cryopreserved using vitrification and stored for future use. And especially for women that are not married and they freeze their eggs. And when the patient is married and she is planning to freeze embryos, the oocytes are fertilized in vitro with partner sperm, or we do ICSI, we inject one sperm in the egg. And then we, the subsequent embryos that arise are cryopreserved using vitrification and stored for future use. We have another therapy, so the generate analogs, and we have to first understand generate is a decapeptide and made up of 10 amino acids arranged in a linear sequence. The secretion of generate is pulsatile, so it's kind of like a pulse, and that is released into the portal system by pulses of different amplitudes and frequencies and frequency. Its half-life is very short, about 2 to 4 minutes. To understand the mechanism of general H agonists, we have to understand the basic basic understanding of the hypothalamic pituitary gonadal axis. Here we have a basic diagram showing the hypothalamus, the anterior pituitary gland, and then the gonads, in this case, the ovaries. The hypothalamus produces gonadotropins releasing hormones of general age, which is a neurohormone produced by the neurons of the hypothalamic apparatus nucleus, and then secreted into the portal circulation of the pituitary gland. And the general age stimulates the anterior pituitary gland to produce LH and FSH. LH and FSH then stimulate the development of the follicles release oestradiol, and then the oestradiol goes and have a negative feedback on the hypothalamus and the pituitary gland. General H agonists are a type of molecule that has been artificially created by replacing some amino acids within the original general H molecule. General agonists have a longer half-time and great affinity for the receptor and the pituitary gland. After agonist receptor binding, a sudden release of gonadotropin occurs, which is known as the flare-up effect. However, if general H agonists continue to be administered continuously, the receptors are eventually blocked and stop responding, so that if it's H and LH secretion is suspended and we don't have any estrogen and no stimulation for the ovaries. We have like choline acetate, triptorelin, nafarelin, buserelin, and gozerelin, and they can be administered daily, monthly, quarterly, depends what you want. Each type of analog also has its route of administration, which may be subcutaneously, intramuscularly, or intranasal. The effect of general H is based on the hypothesis that the resulting pituitary downregulation and inactivation of the ovarian activity would lead to reduced sensitivity to cytotoxic effects. However, activation of the primordial to secondary follicle is gonadotropin independent. So a protective influence cannot be plausibly explained this way. Therefore, the mode of action of GNR8 is currently unclear. So here we'll discover the ovarian tissue cryopreservation. Before the removal of ovarian tissue, the ovarian reserve should be determined to avoid cryopreservation in women with a low ovarian reserve. So we do laparoscopy. Approximately 50% of the ovary is removed, as we see in this photo, from the anti-mesenteric side using scissors without electrical coagulation. And in the FertiProtect network, 50% of the ovarian tissue was removed in 97% of women. The removal of the entire ovary is only recommended for pubertal girls due to the small size of the ovaries. The wound's surface is rinsed to identify the small, mostly subcortical sources of bleeding and to selectively coagulate them. A closure of the wound surface is not necessary. A small sample from the removed ovarian tissue is placed in formalin and handed to the pathologist to exclude metastasis. The removed ovarian tissue should be transferred immediately after removal into a sterile transport medium and transported to processing sits at 4 to 8 degrees Celsius. The transport time is up to 22 plus minus 2 hours is possible with constant cooling at 4 to 8 degrees Celsius, which can be ensured by the special cooling packs and suitable transport containers provided by the respective cryobanks. The preparation and freezing of ovarian tissue. A clean room laboratory with contamination-free environment and a sterile class 2 laminar airflow should be available for preparation. With sterile and cold dissection can be performed. The ovarian medulla should be carefully dissected from the ovarian cortex, and thin residual stoma should be left so that an optimal starting point for the neovascularization of the transplant is available later. Depending on the size and the quality, rectangular pieces of cortex, circa 8 by 4 by 1 millimeter, are cut from the prepared cortex, hold in a suitable medium for cryopreservation, equilibrated, and finally transferred to individual cryogenic vials filled with cryomedia. In a computer-controlled slow freezing process, the samples are cooled so that they can be stored indefinitely in liquid nitrogen at minus 160 degrees. The removal and transplantation of ovarian tissue requires a laparoscopy. The first sign of ovarian activity are seen after 3 months. Here we can see the transplantation of ovarian tissue subperitoneally in the ovarian fossa. And here we see later, 12 months later, how the ovary is looking like into the ovary. So inside the ovary, and then here onto the ovary. As I told, the first signs of ovarian activity are seen after about 3 months, and the fallopian tube, if the fallopian tubes are open and no other relevant safety factor is present, a spontaneous pregnancy may be attempted. Cycle monitoring is often performed. So we monitor the cycle via ultrasound and blood tests. Ovulation is induced with HCG and the timing of sexual intercourse is optimized. The many spontaneous confirm that spontaneous conception can initially be attempted if a pregnancy does not occur or different relevant sterility factors or different sterility factors are present, then IVF combined with ICSI can be carried out. Sometimes we go for combination of 3 main techniques to preserve the fertility preservation before gonotropic toxic therapy. So ovarian stimulation, we can remove the ovarian tissue. After 2 days, we can go with ovarian stimulation. And we preserve the ovarian tissue in order to increase a success rate after highly gonotropic toxic treatment. As we told, 50% of an ovary is removed laparoscopically, and ovarian stimulation we can start after 2 days. Later, according to studies carried out so far, there is no increased complication risk, and the number of oocytes obtained is not significantly reduced after removal of the ovarian tissue. The time required from the combination of both treatment is about 2.5 weeks, and I add almost junior H agonist to the treatment. So here we have a diagram showing how we are going with the patient. If the patient is coming to us and she is coming for fertility preservation, she is young, below 40 years old, and the prognosis are okay, and the future pregnancy is compatible with the patient's health, and she has a high risk of infertility, and we can perform the fertility preservation with low risk. Here we see the time frame. If we have less than 1 week, so we don't have time, so we can go with general H agonist. If we have 2 weeks, we can go with ovarian stimulation. If we have 3 weeks, we can go with ovarian double stimulation, so 2 times stimulating the patient. And sometimes we can go, if we have 1 week, we can go for freezing of oocyte, or we can go with the combination of freezing of oocyte tissue with ovarian stimulation with general H agonist. If we have time frame for 2.5 weeks, we can go for freezing of tissue and stimulation. So here we have a beautiful overview what we can do, and we have pelvic radiation. We go with for ovarian transposition. Breast cancer is the common cancer in women, and that's why I gave this slide. It's nice and important. If we have a high survival rate and the estrogen is sensitive, patient cancer is estrogen sensitive, so we go with general H. We can, if we have 1 week time frame, with ovarian stimulation plus aromatase inhibitor and plus or with general H antagonist or not. And if the cancer is not estrogen sensitive, we have 1 week, we go for less than 1 week, we can offer the patient cryopreservation of ovarian tissue, and we may add a general H. And if we have time frame is more than 2 weeks, we can stimulate. We can go with, we add general H. We can go also with cryopreservation of ovary. So there is a lot of options that we can offer to the patients. So to conclude, the fertility preservation in women provides realistic chances of becoming pregnant. The choice of techniques needs not to be based on the time required, the woman's age, its risks and efficacy, and individual preference of the patient. So the patients need to understand, and we would need to give them time to understand the procedure and to take the best procedure that they like. and be guided in this process. Fertility preservation has become a significant aspect of comprehensive cancer care. The idea of not having a child of her own is a key source of distress in women with cancer undergoing toxic therapy. Healthcare providers should inform women about the effects of cancer therapy and fertility and should discuss the different fertility preservation options available. It is also recommended to refer women expeditiously, very promptly to a fertility specialist in order to improve counseling. Women age, diagnosis, presence of male partner or not, time available, preferences influence and the preferences of the patients influence the selection of the appropriate fertility preservation option. Embryo and oocyte preservation are the standard techniques used while ovarian tissue preservation is new but promising. Despite the importance of fertility preservation for cancer survivors' quality of life, there are still communication and financial barriers faced by women who wish to pursue fertility preservation. Care of patient-facing fertility treating therapies requires an interdisciplinary medical team. This team may be comprised of oncologists, reproductive endocrinologists, urologists, reproductive surgeons, trained mental health professionals, genetic counselors, etc. Fertility preservation programs should have prompt access to appropriately trained mental health and professionals to counsel patients and help them navigate what is frequently a difficult decision-making process. The cancer team should talk about any possible fertility problems that may happen due to treatment as early as possible, either before surgery or before treatment starts. The patients who are interested in fertility preservation might be thinking about it or want to learn more, should be referred to the reproductive specialist. The cancer care team should start talking about preserving fertility as early as possible, to meaning before treatment starts. So, the referrals also to the counseling should be made for people who may be anxious and distressed about fertility effects. So we have to discuss, we have in the oncology, we have to tell the patients about, especially if they are young, about the fertility preservation, and they can choose after this. Ovarian stimulation, including double stimulation and freezing oocyte, is the best established therapy providing lifetime chance in women below 25 years old with high ovarian reserve. So if they have time, it's better before the starting new adjuvant or the chemotherapy. So it's better to send the patients to double stimulation. Ovarian stimulation, including double stimulation, freezing, is the best established therapy as told. Body tissue freezing is especially useful in young women with good ovarian. And thank you so much. But before, I'd like to announce that very soon in health class, we will offer the ovarian tissue cryopreservation transplantation program, led by Dr. Bahouti, who works very hard on it, and Dr. Walid, Dr. Monica, Dr. Assoumi, Dr. Arfan, our IVF lab director, and his team, nurse Sam and her team, and so the management, Mr. Khomsi, who is helping us very much to get this program done. Thank you so much.
Very comprehensive, and you went through all the steps that you people do. So it was very, informative for me to understand what actually you do in these processes and how critical some of those steps are. So that was very, very interesting. It's obviously, something that a miracle of medical science that, we are able to do this now. And I'm just so happy that we have this all available in the UAE with us right here for our patients. There was one question that has already come in the chat box, and I'll encourage all of you to post your questions. It could be related to this topic exactly, or it could be anything to do with female cancers or fertility treatment. We have both the experts here, and they could give you some guidance. If any patients you faced, if any situations in your clinics where you didn't know where to send them or what to do with the patient or what to advise the patient, this is the forum where you can get your answers. One question has already been posted, and that is, can women get pregnant while on treatment for any cancer? So I'm not sure what exactly the person is referring to. This is from Mefi Donna Motil. So if you want to unmute your mic and ask more details, but Stephanie or Nadia would like to comment. Have you had patients who were while on treatment for any of the cancers been able to get pregnant?
I've never had a patient while on treatment who got pregnant. I've had patients obviously with cancer who are diagnosed with cancer during pregnancy. That definitely happens. And then obviously it's a much more complicated discussion with the patient about treatment versus termination versus treatment during pregnancy and prognosis and things like that. So, but I've never had a patient who got pregnant while on treatment.
That be advisable? Do you normally should we advise them contraception while they're on chemotherapy, right? And they should wait for a certain time after chemotherapy has ended, so that I think it would not be advisable also for a patient to even try while they were on therapy.
I totally agree. And the other thing is, especially in IVF and in our fertility clinic. So if the patient that come to us the first time, so to get pregnant, so it's very important to check the breast, because we have breast cancer is one of the common cancer, and check the breast because if you see in the mass, we don't let them get pregnant. First, they have to go to oncologist and all to investigate prior to any pregnancy, and then also the pap smear, cervical cancer. So that's why we have to be proactive in this and given the awareness. We don't have to start any stimulation before really investigating the risk. If patient has any mass in the breast, has to be evaluated, and pap smear has to be good, and then we can go. So that's we are eliminating or we are reducing the cancer in pregnant patients. Because if they are pregnant, we are really in trouble. Because if you give chemotherapy, we may disturb the embryo, but if we let her like this, she may have metastasis. Yeah, prevention is important.
Just continuing on this about what Stephanie said about having patients in pregnancy who are then diagnosed with cancer. Very often I get patients in the clinic who are either pregnant or breastfeeding and who felt a lump. And clinically, it might be a fibroadenoma, or it might be a milk collection while they're breastfeeding. But what is your advice or your experience on getting them tested or screened with an ultrasound at least at that point? Or should we just reassure them? Because most of the radiologists ask us to send them only when they've completed their breastfeeding. So what is your...
So I'm not an expert in breast cancer, but I would think that, something like an ultrasound or even if necessary, an MRI of the breast is safe in pregnancy or while breastfeeding. So I think that early detection is always better than waiting. So as an oncologist, I would say, no, send the patient as soon as possible, as soon as she feels anything abnormal for evaluation, because these things can be done during, biopsies and things like that. Those things can be done during pregnancy and they can be done during breastfeeding as well.
I agree with Stephanie. Any mass, anything in the breast, we cannot ignore. We have to do biopsy, we have to do ultrasound, we have to investigate ultrasound, MRI, and go for biopsy. It's minimal invasive, and then we are having diagnosis.
So Mefidona Motil, who asked the first question about women getting pregnant while on treatment, is asking that, but our contraception is not always 100% effective. So what if they get pregnant?
So if they get pregnant and they're on treatment, it's going to depend on the type of treatment they're getting. So, something like radiation, that is going to terminate the pregnancy if, something like pelvic radiation. But chemotherapy, Generally, it's recommended that chemotherapy be avoided during the first 12 weeks of pregnancy, but then in the second and third trimester, not to say that it's safe, but it's tolerated by the fetus. And obviously there are things like complications, where fetuses are smaller than normal, and there's, his risk of preterm delivery. But other than that, there's actually decent data looking at women who receive chemotherapy in pregnancy, and actually in the second and third trimester, it's safe with most chemotherapy. Most chemotherapies, not ideal, but it's not an ideal situation. So
at the end of the day, the oncologist and the obstetrician and we have to sit together with the patient and see what are the risks. Like if you said, if she got pregnant while on chemotherapy, we may have to think of postponing to the second trimester and stopping for a few weeks. And how risky is that going to be for her cancer, et cetera, et cetera.
And something, if something like unfortunately, if the pregnancy it's unknown that the patient's pregnant and realizes that she's been getting chemotherapy and she's pregnant, she's definitely going to want to consult with maternal fetal medicine, because she may have, the fetus may have developed congenital anomalies from the chemotherapy, and she may need to terminate the pregnancy. So.
What is the youngest age where you can do ovarian preservation? Youngest age for a woman, like in your experience? Or
I have only one case that's 13 years old, so we remove the ovary, and this is the case that I know. And with 27, actually she was 27, we transfer the ovaries. Yeah, this is.
I think, Dr. Nadia, the patient. Does the woman have to go through puberty before the ovaries are able to be used for cryopreservation?
But yes, ovarian. We are discussing about ovarian tissue transplantation. No.
Good morning.
Yeah? We are discussing about ovarian. Good morning. Ovarian tissue transplantation. You are discussing.
Can I suggest some? Can I say something, please? I'm Dr. Irfan. I'm the IVF lab director in Health Plus Abu Dhabi. As Dr. Nadia mentioned at the end of her lecture, that Health Plus is going to initiate this ovarian tissue cryo freezing program very soon. We were there in Copenhagen in the beginning of December, and the team of embryologists and the team of clinicians to underwent a training program by one of the biggest group who is doing this ovarian tissue cryo freezing program in the world. And there it was discussed what kind of ages can be subjected, the patients can be subjected to the ovarian tissue cryopreservation. And for what I gathered there was that there is no younger limit. So the youngest patient they had frozen, like for example the leukemias, they can happen in very early in life. And sometimes the treatment is so harsh that it might render the child infertile. So they have frozen the tissue of a youngest one there in their record is 2 years old.
Wow.
So they have frozen it, but unfortunately the problem in this case is that the ovarian tissue is too small. So it is a very, very critical to have a proper procedure done. So in this case, there is no clear-cut demarcation between the medullary portion and the cortex portion. So they freeze even the medullary portion of the ovarian tissue itself. But after this one, the patient needs a long time to go into the puberty and remission and all this. So maybe another 20 years or maybe more than 20 years before the transplantation can occur. But it is possible to freeze the ovarian tissue for even very young patients. Thank you.
So, as Dr. Afan told, it's very experimental. We don't have a lot of data for young people below, very pubertal. So we don't have too much data about it. I know only one 13 years old, but on her age of 27, she went for transplantation of the ovaries. We have to know also that the slow freezing and the freezing, if we freeze, we transplant all the follicles are diminishing too. So we have to explain this to the patients that if we are freezing longer, it may be that the follicles number are declining. So it's better that to freeze, and then if the patients have a partner, and then we transfer the transplant and to get pregnant quick. That's why we don't remove all the ovaries. We let one. Perhaps it will not be. And we are not 100% sure of the chemotherapy. It depends on chemotherapy, if we are taking alkaline or something like this. It depends on a lot of things. So that's why we have to know which chemotherapy, which aggressive chemotherapy, and the effect of the ovaries. We have to discuss about the ovarian reserve and a lot of factors that we have to discuss. And it is very multidisciplinary. It's not about, as Dr. Stephanie, she will speak with the patient, and then I have to speak with Dr. Stephanie, and we see the best things, what we can do for the patient, and the patient to have to agree or not. And we go, if we see the prognosis not good, if we see a lot of things, we don't do all these things. We don't harm the patient. So it depends. It has to be good prognosis, and it has to be for the transplantation or for the tissue care preservation of the ovaries. Good prognosis, healthy people, and a good ovarian reserve. So a lot of factors play a role. And the time frame.
That brings me to another question, Dr. Nadia, that quite of these gynecological cancers are hormone dependent. And then we use a lot of hormones to stimulate, to get those, to get ova to freeze and preserve and embryos. So is there any studies, any data to say if that helps? Does that cause more recurrence? Does that cause more, cause of other hormone dependent cancers?
For example, not all the cancer are hormone sensitive, but we take the breast cancer. For example, the breast cancer, if the patient is sensitive to estrogen, so it's positive, receptor sensitive to estrogen or progesterone, so we go with aromatase. So we go with anti-estrogen in order to decrease the estrogen level, and in order to also decrease the chance that the cancer will grow. But we have new adjuvants, so I found it's okay. We can stimulate, and we have a good data. We have a big data about it, so we can stimulate patients with receptor positive. We give aromatase, as I show in my diagram, and then with aromatase we have, if we stimulate, even we have a lot of follicles, the estrogen level is very low. It's like 300. So the patient, it's herself without anything, she is ovulating. If we don't stimulate her, and she is producing estrogen or almost 300. And so with our stimulation, though we have more follicles, with aromatase, we are decreasing the estrogen level. And we trigger junior age, which is making atresia of the corpus luteum after the trigger. So the estrogen is doing a quick down, and this is only short term. It's okay, we can do.
Yeah, and also just to add to that, so for endometrial cancer, the hormones that are given are balanced, so it's not going to increase the growth rate of the endometrial cancer. It's also given over a short period of time, so the effect is nil. And then there's pretty good data in something like a borderline ovarian cancer, which is estrogen sensitive, and it's not shown any increase. Sorry, give me 1 second. It's not shown any to be increased. The infertility treatment has not been shown to increase recurrence rate or malignant transformation, anything like that in borderline tumors. And the other types of ovarian cancers tend not be as estrogen sensitive. So I don't think and cervical cancer is not at all hormonally sensitive. So really there's no risk in GYN cancer to do reproductive freezing or preservation.
And the short term also, when we stimulate, it's only short term increase of estrogen. It's less than 2 weeks. Yeah.
Are there any ways, if a young mother had colon cancer and received radiation, can she be offered option of fertility? So after radiation therapy for colon cancer, what is the status of fertility and what are the options this patient has?
So if the patient is getting healthy and we will assess the patient, she will come to us, we will assess, we'll do ultrasound, we'll check the ovaries, we check if the oncologist gave us non-objection to go for pregnancy. So we will assess first the ovarian reserve, we will assess the ultrasound, check the entire follicle count, and then we'll discuss all the options. Depends if she has good ovarian reserve, she can go with time to intercourse. For example, we stimulate especially if everything is good and she is young. And depends if she is old and she doesn't have time, we can go for IVF. If we see that the ovarian reserve is low, or she tried long time and she didn't get pregnant. So it depends of the situation. It's really complex. It's not like we do this or this. We have the patient's factor, we have the ovarian factor, we have the partner factor, we have tumor factor, we have a lot of factors playing a role, and then we evaluate this, we discuss with the patient, we explain, and then patients, they have to know, and this is very important, they have to know their chances with IVF or with chances with all the treatment that we can offer, like time to intercourse, like IUI, like IVF, and this has to be explained well to the patient so that she can choose the therapy which is good for her. And she has to know the risk, the chances, and we have to know her family planning. It's a lot of factors playing a role. It's very complicated, very easy if the patient in front of you to do, and you explained, but to explain now, it's from patient to patient, it's different.
Yeah. The other thing with the colon cancer is if the patient's getting pelvic radiation for colon cancer, depending on the dose to the uterus, that can also be a factor. So if the uterus is able to be saved a critical dose, then pregnancy is safe. But if the uterus gets too much radiation, then the patient may not be able to get pregnant herself after that. There are a couple of experimental programs in the United States that are doing something called uterine transposition. So similar to the ovaries, the uterus prior to radiation is transposed out of the pelvis. Because the patient actually continues to menstruate through her treatment, it's actually the cervix is brought up through the umbilicus so that she menstruates through her umbilicus. So that she's not menstruating into her abdomen and causing peritonitis. And then after treatment, the uterus is transposed back. But of course, this is not like a standard procedure. This is all experimental. So
very good, and very important by colorectal carcinoma. We have to know if it's hereditary or not, because if hereditary, we'll discuss with the patient to go for genetic counseling. And then we can go for IVF, we'll go for PGTM, so for pre-implantation genetic testing we search the gene, the single gene, and then we can help the offspring to don't have this cancer in the future. Other thing is with radiation, if we have colorectal carcinoma and they have sometimes pelvic radiation, if they got the radiation, the endometrium could be not good, and then they have a high miscarriage rate. So they have to know all these things.
A couple of other questions is that for endometrial cancer, Stephanie, in between pregnancies, like if a person has been diagnosed with stage 1 and is, taken some progesterone, planned a pregnancy, gotten pregnant, then in between the pregnancies also, should we be doing a 3 to 6 monthly biopsy, like if she wants to have more than one?
Yes, I would. I would be putting that patient on progesterone treatment between pregnancies.
So while she's breastfeeding, what should we put her on?
Well, something like an IUD is very safe for breastfeeding. I mean, that's why I love the IUD. I think it's just such a good option for so many women.
Does Cerazette, the progesterone only pill, the mini pill, have a similar effect, or you think Verena is still the better choice?
I think so. I think any progesterone would be adequate as long as she's not developing a new lesion or progressing.
While the Marina is in, we can do the biopsy.
Yes, I do
radiated.
it. I do it in the office actually while the IUD's in.
Without hysteroscopy, you can just do a blind biopsy, or do you do it with
Yeah.
hysteroscopy?
Yep, I do a blind biopsy. The endometrial biopsies are actually 95% sensitive. So they're very good.
Biopsy with the Marina in situ. We just take a biopsy and do this every 3 to 6 months, right?
Correct. I do every 3. Yeah.
Okay. And Dr. Nadia, I just wanted to know, and also, sorry, Stephanie, one more question. How soon after trachelectomy? Sorry, you were saying something?
No.
Okay. So how soon after trachelectomy can we like encourage a person to get pregnant or try?
So yeah, so I mean, I would be interested to see what Dr. Nadia says, but from a surgical standpoint, as long as they're healed, so maybe 6 to 8 weeks following the trachelectomy, you know, they're healed, so they can probably pursue, you know, it would be IVF, you know, at that point, because they can't get pregnant spontaneously. So.
Stephanie,
8 weeks after the surgery, once the surgery is healed, they can then go for IVF and start planning. And hopefully they would have had either eggs or embryos also saved.
Correct.
And they can start it straight off. Yeah. Okay, just one more question, Dr. Nadia. When you discussed about this situation where you did ovarian preservation with laparoscopy, and then in the very same cycle, you started with ovarian stimulation as well, and then you retrieved those. So what is the advantage of doing both of them in the same cycle? Is it just to save time?
not only to save time, but to give them the best, especially if we know this patient, she will have a very strong chemotherapy, which is toxic. So we know this already because we discussed with the oncologist, yeah? So we know it will be disturbed in 80% or 85%. So to maximize their chance to get pregnant in the future, we can go for, we take half of the ovary, for example, and we freeze it, and then we stimulate after 2 days. And we have Fertility Protect in Germany, Austria, and Switzerland are very good on this. So we have a lot of big data, and not only data which is clinical data. So those patients, they have to they have to know the risk. The risk of laparoscopy is same like laparoscopy, so it's not something big. We freeze the ovary cortex. They have a chance later if because if we stimulate, we have embryos, for example, or eggs. We don't, if we have eggs, for example, patient is not married and we freeze the eggs. So we have to throw the eggs one day if she has a partner. And throwing the eggs, some they will survive, some will not survive. So they have, all the patients have to understand how many eggs we have to accumulate in order to have a chance to get pregnant, or at least a good probability to get pregnant. So if the patient is 35 years old, she needs at least 6 eggs. But if she doesn't have too many eggs, if we have 6 eggs with freeze, she may need more cycles, for example, in order to have a good chance to have 2 or 3 or 4 good embryos or healthy embryos or eukaryotic embryos. So sometimes we need more cycles, and then we don't have this time frame. We don't have the time. That's why the combination of tools are good, because then we have the ovarian tissue cryopreserved, which we may transfer, and we have like more than 200 people, patients where we transferred the ovarian tissue and they got pregnant spontaneously or via IVF. So the chance is getting good, and then we have the embryo frozen, so the security is good. Patient should feel better secure, and the chance, because we don't want to freeze eggs, we want to have a realistic chance to get pregnant. We don't want to freeze tissue, but we have to have how is the chance to get pregnant after a transplant, and this has to be discussed with the patients. And here it depends of the ovarian size, it depends of the age of the patients. So a lot of factors play a role. So before doing cryopreservation of ovarian tissue, we have to consider a lot of things. Patient has to be young or more below 38, better below 35. The ovarian reserve has to be good. And the willingness and all this that she is willing. So in order to maximize, we do the combination of three. I give almost general H because I found general H because in 50% we can really preserve the ovarian. So reserve, that's why we reduce to premature insufficiency, premature ovarian insufficiency in 50%, we can reduce it. So we give this general H to preserve the ovary, and also so that the patient doesn't have her menstruation. And if each patient is taking chemotherapy, we don't want people to bleed because they have already, with chemotherapy, they have anemia and cholestasis. So there is a lot of effect that we have to explain. And this very rare, to do all this, the two combination ovarian transplant, ovarian tissue extraction and stimulation. But we have.
One question that we have is, so can this whole fertility treatment for a patient with cancer get covered under insurance because it's being done for a medical condition, or it's still not covered, like for non-TICA patients?
I really don't know, but I do hope that to have to be covered, because with the TICA patients that are covered, that are single, not single, that are covered. Not TICA patient, I don't think so. But
Stephanie,
we do the consultation. I offer the consultation for free for everyone. It's very important because this consultation is very, very important. Even psychologically is important. And because the patient, if they have cancer, they are really like they have an accident, they don't want even to think too much. And then we as healthcare professionals, we have to, because they cannot, because they are really in stress and they cannot be reasonable and thinking. That's why we have to guide them. And often the oncologists and like breast cancer, we can eliminate this breast cancer, we can kill breast cancer, but then it will be like very futile if we diminish with it the fertility of the patient, and because she doesn't know. That's why the knowledge is important. Yeah.
Any fertility sparing surgery like transposition of ovaries before therapy, would that usually be covered with insurance?
Yes, usually the surgery is covered. Yes.
And then get an idea about what really involves. Sometimes we have a wrong idea.
Dr. Neha, I don't understand because it was mute. Sometimes it's we don't.
I'm just saying that it's good to know that there are these options are there, and also about insurance issues, because a lot of patients here are afraid to go for treatments because they think it might be very expensive or not covered. But I think it's a very good thing that you're offering them initial free consultations, so at least they know what is available to them, what are their options, and also the financial implications.
And then we have a financial counselor, and here we are helping in Health Plus. We are helping patients even financially. They are reducing a lot of prices for them in order to go for the treatment and to preserve their fertility. So there is a lot of help for these centers that are helping very well the patients.
I've got any more questions from the participants? I've just got a lot of comments where they have found Dr. Ishraq has written, it's a really informative lecture. A lot of comments thanking both of you for the interesting lecture, being very informative. Dr. Shahida Ashraf has written, Sam has written, Dr. Parveen, Dr. Kavita. So a lot of comments here. You may go through the chat box with thanking you for the informative lecture. And I personally have really enjoyed it, and it's been very, very nice and informative. And I think this is the need of the hour, where we need to know, we need to collaborate and need to offer patients combined treatment, so that like you both have mentioned multiple times in your sessions, that it's not just about treating the cancer and then not letting them have a pregnancy. So even the oncologist has to start this conversation, the primary care provider, the gynecologists, the fertility specialists, of course. So we all need to speak the same language, give them hope, give them the right direction, the right guidance. And I think a lot of women will really benefit from this collaboration. So thank you both for giving time, and please, last words.
Yeah, I'd like to tell, I'm very happy to work with Cleveland. So the doctors are amazing. They send the patients to us. They call me, they send an email. We have a nurse taking care of this. And there is a good collaboration with Dr. Stephanie. She has my private phone number with patients. She will call, I will take the patient the same day or the day after. So the IVF lab will open for the patients, especially men, if they have to freeze the sperm, because the day after they have to do operations. So we do everything. And even they don't have to pay for, sometimes they cannot pay, we give them this sometimes for free, or we reduce the prices to freeze the sperm and to help them in this situation. And the most of the patients, and I think all the patients that are very thankful, very thankful that they see us, because if they are referred to the oncologist to us, they feel that it's like psychological counseling too, because they feel that somebody listened to them, and because they don't have time to go to mental health, and then they feel supported all together. We can help, because this is what patient needs. Patient needs to be supported, and Fertility here in Health Plus, we are open for them. They can come anytime. They have the priority of the onco patients. Yeah. Thank you so much for everything. Thank you, Stephanie. Thank you, Neha, for the invitation.
My turn. So I was going to say that the one thing I say to all the patients is, even if fertility is not something you think you're going to want in the future, please just go and have a consultation with Dr. Nadia, and at least speak to her about the options. And because even if you're not worried about it now, and you're only concerned about your cancer, which is normal, and you're concerned about treatment for your cancer, this is going to come up later for you, and you're going to wish you had done something about it. So I just say, even if financially you're not sure, please just go and speak to her. So that's what I would say is just make sure that the patient at least has the information that they need, and they've spoken to a consultant, a specialist, about their options, so that the patient at least is informed of what is available. Oh, you're muted.
Sorry. So yeah, I think that's really going to make the change in the region. Your presence here is really already making a difference. And, having specialized care with so much experience behind you, it's really going to make a difference to the kind of care. And I think the collaboration between both the teams is really doing so good. So thank you both for today and for everything else that you do every day. Before I end, I'm just going to share my screen to talk about the questions people have had about the certificate for this CME, because that's also very important for everybody to get their CME points. And so this is, if you can see my screen, this is basically the steps that we have, we will be sending to you in an email as well. So now from the last year, DOH DOH accredited programs like this one, we are not allowed to give the certificates to you directly. The certificates have to come from DOH for all those people who are licensed in DOH. So you have to go to TAM, you have to log in with your UAE pass, select the Department of Health, and then go to a new request and choose participate in medical education program. There's a list of all the sessions that have been approved by DOH. You can select fertility preservation in women with cancer, and it's in two parts. So part 1 and part 2, select both. And then when you do that, we will get a notification, and then our team will check if you have participated and if you've completed the surveys. We will approve your participation, and then you will get a message from DOH that your certificate is ready and you can download it. So if you need any help from us in approval or in accelerating that process, we can help, but we cannot apply for you, and we can only approve your participation. The certificates will come from DOH. However, if you're not licensed with DOH, if you're working anywhere else in UAE or abroad, you can then send a mail to Academic Affairs. Anit will just post that link in the chat box. And you can ask for which part you've attended, part 1 or part 2 or both, and then we can send you a certificate for that. But that certificate will not be accepted in DOH for your license renewal. So it's best if you get the certificate from DOH for the license renewal purposes. So I hope that's clear, but if you have any other questions, please email to Academic Affairs, and our team, Anit, Sonal, Tahira, and myself, will try to clarify and help you as much as we can. But please do apply within the next 2 months at least, because DOH then removes that CME from their website and you cannot apply for it even if we try to help you. So please make sure you applied for it within the next 2 months, and then we will approve it as soon as possible. So I hope that clarifies all the questions about the certificate as well. And I hope all of you have enjoyed the session as much as I have. And we have another exciting news to tell, that our next session will actually be a little bit delayed. It's on 8th of February, but it's going to be a very, very interesting session. It's going to be in person in Danat Al Emirat Hospital by Virginie Meberek, our clinical psychologist. She will be taking us through practical tips on how to go about CBT and mental health assessment in our clinics, in our peripheral health settings, in our day-to-day gynecology, pediatric, physician, any clinic that you're running, or if you're a nurse, how to help a patient, how to pick up mental health issues, how to help guide them and initiate their healing process from day one. So please look out for that information and do join us in Danat Al Emirat Hospital on the 8th of February, and more details will follow. So thank you very much, everybody, and hope you had a good time. Have a great day. Bye-bye. Bye, Dr. Nadia. Bye, Stephanie. Thank you. Bye, Annette. Bye, Sonal. Thank you very, very much, Jerry. Bye-bye.